When we think of saving a life in a medical emergency, our minds almost instantly jump to the cinematic stuff, right? Like we picture the chaotic rhythm of chest compressions or, the defibrillator paddles charging up while someone yells clear.
Oh, totally. Or maybe like the intense high-pressure application of a combat tourniquet. It's dramatic, it's highly visual, and, well, it makes for really great television.
Exactly. But the reality of emergency medicine is grounded in a much more fundamental biological hierarchy. Because, none of that dramatic intervention matters if air literally cannot reach the patient's lungs.
Right. It is the ultimate prerequisite to saving a life. The human body can survive for weeks without food, days without water, but only minutes without oxygen.
Yeah, and today, for you, the listener, we are looking at a procedure that sits at the absolute foundation of human survival. Yet it rarely gets any Hollywood spotlight. We are looking at the meticulous high-stakes process of oral suctioning.
Because before a rescuer can breathe for a patient, or, before they can deliver any supplemental oxygen or administer life-saving drugs, they absolutely must secure a clear pathway.
Right. If the airway is obstructed by fluid, every other intervention you attempt is just functionally useless.
Exactly. You are just wasting time you don't have.
So to understand exactly how rescuers secure that pathway, we're working from a really specific stack of sources today. We have a highly detailed clinical grading sheet, like the exact kind of strict, bullet-pointed rubric used to evaluate emergency medical technicians.
Yeah, it's very rigorous.
It really is. And alongside that, we have a series of instructional field images that visually break down the equipment and the physical techniques.
Which is super helpful for visualizing this stuff.
Definitely. So the mission for this deep dive is to explore the step-by-step precision required to clear a compromised airway, and to understand the underlying physics and anatomy that make every single action on this grading sheet literally a matter of life and death.
Okay, let's unpack this. To really grasp the severity of the procedure, we first need to understand the biological geography we're dealing with here.
Right. So the primary battleground here is a region of the anatomy called the hypopharynx. If you picture the back of the throat, the hypopharynx is the lowest portion. It sits just above where the anatomical road basically forks.
Like a literal fork in the road.
Yeah, exactly. One path leads down the esophagus to the stomach, and the other path leads down the trachea to the lungs. It is effectively a funnel.
Okay, a funnel.
So the therapeutic goal of oral suctioning is to aggressively remove vomit, mucus, blood, or any other fluid that is pooled in that funnel.
Because if fluid sits at that fork in the road, you are looking at two immediate catastrophic threats.
Right.
Precisely. The first threat is just mechanical obstruction. A thick pool of blood or heavy mucus can literally block the opening of the trachea like a plug.
Just stopping oxygen from entering entirely.
Exactly. And then the second threat is aspiration. This happens when the pooled fluid spills over the vocal cords and is inhaled deep into the delicate tissue of the lungs.
And from what I understand about aspiration, especially if you're talking about vomit, you aren't just drowning the patient. You are introducing highly concentrated stomach acid into the fragile alveoli where gas exchange happens.
Yeah, it is incredibly destructive.
That acid will chemically burn the lung tissue from the inside out, won't it?
It does. It causes a devastating condition called aspiration pneumonitis. Even if the patient survives the initial emergency, those internal chemical burns severely compromise their ability to process oxygen for days or even weeks afterward.
Wow, so it's a lingering problem.
Oh, absolutely. It often leads to secondary fatal infections. So the rescuer is fighting an immediate threat of suffocation and a delayed threat of chemical destruction simultaneously.
Geez. That brings us to the actual hardware. Our sources give us a very clear look at the tools designed to fight this. One of the field images shows a portable suction unit resting on the grass next to a patient.
Yeah, the white rectangular machine.
Right. It looks a bit like a specialized air compressor. It has a clear collection canister strapped to the side to hold the fluid, a really precise analog pressure gauge on the front, and clear tubing extending outward.
And attached to the end of that tubing is the primary instrument of the procedure, the rigid tip, which is widely known as the Yankauer catheter.
The Yankauer, yeah. It's a fascinating piece of medical design. Visually, from the images, it is a hard blue plastic wand with this distinct ergonomic curve.
Yeah, that curve actually mimics the natural slope of the human palate and throat. And the tip is bulbous rather than sharp, with several large holes.
So it won't just stab the back of the throat.
Right, exactly. It is engineered specifically to handle the adult anatomy and to rapidly clear massive volumes of thick, viscous material. Think heavy vomit or blood clots. It can handle all that without constantly clogging.
But the clinical sheet also mandates mastery of a second tool for entirely different scenarios.
Right?
The soft tip or the French catheter.
Yes. And this is a complete departure from the Yankauer. It is highly flexible. It almost resembles a long piece of hollow spaghetti.
Hollow spaghetti, yeah, that's a good way to picture it. And the grading sheet notes this is utilized for infants, for clearing out nasal passages, or for suctioning through advanced medical airways like stomas or eye gels.
Because you have to match the physical properties of the tool to the structural integrity of the pathway.
Makes sense.
The adult hypopharynx is relatively robust. It can handle the hard plastic of the Yankauer. But if you attempted to force a rigid plastic wand into the tiny, fragile airway of a newborn infant,
Oh, that sounds awful.
it would be. Or if you pushed it up into the delicate turbinates of a nasal cavity, you would cause severe mechanical trauma. So the French catheter allows the rescuer to snake the vacuum into narrow, vulnerable spaces safely.
Wait, hold on a second. You're talking about shoving an active vacuum tube into the back of someone's throat while they're physically compromised. Are there any situations where you absolutely cannot do this?
What do you mean?
Like if the patient has severe facial trauma, or a crushed windpipe, or maybe some underlying throat cancer, there has to be a contraindication, right?
What's fascinating here is that the clinical guidelines state the exact opposite. There are absolutely zero contraindications for clearing an airway. None.
Wait, really? Zero. In almost every deep dive we do on medical procedures, there's always a list of warnings about when to withhold a treatment to avoid making things worse.
I know that rule normally holds true, but you have to look at the raw biological math of this specific emergency. If a patient is drowning in their own bodily fluids and lacks the neurological or physical ability to clear it themselves, the mortality rate is 100%.
They will just die.
They will die rapidly. While severe facial trauma or delicate medical conditions require extreme caution and a highly delicate touch, the rescuer just does not have the luxury of withholding the procedure.
Because doing nothing means certain death.
Exactly. There is no pre-existing condition on Earth that makes suffocating to death an acceptable medical outcome. The fluid must come out.
The stakes literally could not be higher. That moves us to the physical execution. The grading sheet lays out the preparation sequence, and it starts entirely with the rescuer's safety.
Body substance isolation.
Mm-hmm.
BSI.
Right. Gloves, eye protection, masks. I mean, if you were suctioning fluid from a violently coughing or sputtering patient, the risk of biological splash is immense.
Oh, it's a huge hazard. And if a rescuer takes a splash of blood or vomit to the eyes because they rushed the procedure without a mask, they have instantly compromised themselves.
They basically become a second patient.
Exactly. They become a second patient, breaking the chain of care for the person dying on the floor.
Okay, so once the rescuer is protected, the sheet mandates testing the portable unit. You power it on, kink the tubing to block the airflow, and watch the pressure gauge. The protocol requires the machine to hit a minimum of 300 millimeters of mercury.
Yeah, and we need to contextualize what 300 millimeters of mercury actually represents. It is a measurement of negative pressure.
Vacuum power.
Right. Blood, heavy mucus, and particulate vomit are incredibly dense, viscous fluids. To pull a dense, heavy liquid up a plastic tube against the downward force of gravity, well, that requires immense raw vacuum power.
Right, because if the machine cannot achieve that 300 millimeter threshold, it will merely pull at the fluid weakly.
And leave the airway obstructed.
But immediately after confirming that massive vacuum power, the clinical grading sheet highlights a really critical step. The rescuer must turn the machine back off.
Because an active, open vacuum generating that much negative pressure is a serious hazard in a chaotic environment.
Like it'll just stick to things.
Yeah. If that catheter tip brushes against a blanket, or the rescuer's own clothing, or even the delicate skin of the patient's face before the rescuer is fully prepared, it will latch on instantly. The machine remains off until the rescuer has absolute intentional control over the catheter.
Wow. Okay. So with the machine armed and waiting, the protocol dictates physically preparing the patient. The primary instruction is to turn the patient's head to the side.
Yes.
To me, this is a brilliant application of basic mechanics. It's exactly like tilting a heavy bucket to let water spill out over the rim.
That's a great analogy.
Instead of fighting gravity by trying to vacuum fluid straight up out of the back of a supine patient's throat, turning the head utilizes gravity. The blood or vomit naturally slides out of the hypopharynx, pools in the lower cheek, and drains toward the floor. It just makes the suctioning vastly more efficient.
Gravity is the rescuer's greatest ally in this scenario. You use the Earth's pull to move the fluid away from the vocal cords. However, and this is crucial, one of the field images in our sources highlights the sole, unyielding exception to this mechanical advantage.
Ah, yes. The image of the young boy lying in the grass.
Right.
He is flat on his back, and the rescuer is actively using the Yankauer catheter to suction his airway. But the boy is wearing a rigid cervical spine collar, and the rescuer has completely ignored the rule about turning the head. The head is locked perfectly straight, facing the sky.
Because the presence of that C-collar indicates a suspected cervical spine injury, the vertebrae in the neck might be fractured, and the delicate spinal cord could be exposed.
So turning the head is out of the question.
Completely. If a rescuer were to aggressively twist that patient's head to the side to let gravity drain the vomit, the broken vertebrae could easily slice through the spinal cord. That causes instant, permanent paralysis or death.
Oh, man.
So in that specific trauma scenario, the rescuer must abandon the mechanical advantage of gravity. They have to keep the head locked in a neutral position and rely entirely on the raw horsepower of the suction machine to fight gravity and pull the fluid straight up and out.
Here's where it gets really interesting, because the procedure then transitions from spatial positioning to rigorous geometry. The clinical sheet demands that the rescuer physically measure the Yankauer catheter against the patient's face before it ever crosses the lips.
You cannot simply insert a hard plastic tube into a human throat based on guesswork. It's too dangerous.
Right. The visual sources show a rescuer holding the Yankauer alongside a medical training dummy's face. They're measuring the distance from the outside corner of the mouth to the sharp, bony angle of the jawline, and then clamping their fingers tightly onto the plastic tube at that exact mark.
Yes.
But why that specific line on the face? Like, what does the angle of the jaw have to do with the throat?
It is a proportional roadmap built into human anatomy. The external distance from the corner of your lips to the angle of your jaw perfectly mirrors the internal distance from your front teeth to your hypopharynx.
Oh, wow. I had no idea.
Most people don't. By measuring that external line and pinching the tube, the rescuer creates a physical custom depth gauge for that specific patient.
So your fingers act as a literal stopper to prevent the tube from going any deeper. I imagine this prevents you from missing the fluid entirely by not going deep enough. But more importantly, it prevents you from ramming a hard plastic wand into the vocal cords.
The vocal cords and the surrounding tissues are profoundly sensitive. If a rescuer panics and shoves the unmeasured Yankauer too deep, they will strike that tissue. The resulting mechanical trauma will cause the airway to instantly swell shut or induce severe bleeding.
So you would take a fluid obstruction that could be vacuumed out and turn it into a swollen tissue obstruction that cannot be bypassed at all.
Exactly. The measurement is non-negotiable.
Okay, so the geometry is locked, the depth is set. Now we hit the physics of the vacuum pressure, and this is where the grading sheet gets incredibly strict regarding the patient's age.
Very strict.
For adults, the vacuum is set between 120 and 200 millimeters of mercury. For children, it's capped at a maximum of 120. And for infants, it cannot exceed 80 millimeters of mercury. Wait, if an infant is literally choking on a pool of fluid, capping the vacuum power at 80 seems dangerously low? Why wouldn't you hit it with 200 millimeters to clear that obstruction instantly?
If we connect this to the bigger picture, we have to look beyond just the mechanics of moving fluid. The human body is a highly sensitive electrical system, right? And the back of the throat is heavily wired with the vagus nerve.
The vagus nerve. That is the cranial nerve that extends from the brainstem all the way down through the chest and into the abdomen, controlling a lot of our involuntary functions.
Exactly. It connects directly to the pacemaker cells of the heart. Many people have actually experienced mild vagal stimulation in their daily lives.
Like when?
Well, it is the underlying mechanism when someone sees blood and suddenly feels lightheaded or faints. It's known as vasovagal syncope. The nerve is triggered, and it tells the heart to slow down.
So the back of the throat is packed with these vagal nerve endings.
Yes. Now imagine aggressively shoving a catheter into an infant's tiny throat and hitting that sensitive tissue with a massive 200 millimeters of mercury vacuum pressure.
That sounds like a lot of force for a tiny throat.
It is. The sheer mechanical aggression of that suction deeply stimulates the vagus nerve. The nerve violently fires a signal to the infant's heart, commanding it to slow down. This is called reflex bradycardia.
So their heart rate just plummets.
It plummets dangerously. Infants are extraordinarily susceptible to this because their baseline heart rates are much higher and their parasympathetic nervous systems are highly reactive. If you ignore the 80 millimeter pressure cap to try and clear the fluid faster, the excessive vagal stimulation can literally stop the infant's heart.
You would solve an airway problem by instantly creating a fatal cardiac arrest.
Exactly.
That is deeply terrifying. You are walking a razor's edge between clearing the fluid that is suffocating them and accidentally triggering their own nervous system to shut down their heart. It completely recontextualizes the pressure dials on that machine.
The numbers on the grading sheet are not mere recommendations. They are strict physiological boundaries designed to keep the patient biologically viable.
Unbelievable. All right, so the depth is measured, the pressure limits are locked, the physical intervention finally begins. The first barrier is the mouth itself. The clinical sheet dictates opening the airway using the crossfinger technique.
Right.
That's where the rescuer scuffs their thumb and index finger together like a pair of scissors to pry the teeth apart. Why use that specific motion?
Because the human jaw is incredibly powerful, and a patient who is severely deprived of oxygen is often in a state of primal panic.
They aren't thinking clearly.
Not at all. If a rescuer simply hooks their fingers inside the mouth to pull it open, the patient's hypoxic brain may trigger an involuntary clamped bite.
Ouch.
The bite force can easily break the rescuer's fingers, taking them out of the fight entirely. The cross-finger technique uses mechanical leverage against the teeth to force the jaw open safely while keeping the rescuer's digits completely out of the crush zone.
Clever. So once the mouth is open, the rescuer inserts the catheter to their exact finger mark depth. But the manual emphasizes a counterintuitive point. They must insert the catheter without suctioning.
Right. The machine is on, but the thumb port is open.
Yeah, they only cover the thumb port to activate the vacuum after the tip has reached the hypopharynx. Why not just hold the vacuum on the whole way down to clear a path?
Because the inside of the mouth and throat is lined with delicate mucosal tissue. If you maintain an active vacuum while pushing the catheter forward, the tip will grab the side of the cheek, the tongue, or the palate.
It'll just suck right onto it.
Exactly. And as you continue to push, you will forcefully strip and tear that mucosal lining all the way down. The protocol requires a silent, unsuctioned insertion. You navigate carefully to the precise depth, activate the vacuum, and only clear the fluid on the withdrawal, sweeping side to side to catch everything on the way back out.
But the withdrawal process is where the strict clinical sheet introduces the most brutal constraint of all, the time limits.
Oh, yeah. These are critical.
Rescuers are forbidden from suctioning indefinitely. For an adult, the absolute maximum time allowed is 15 seconds. For a child, 10 seconds. For an infant, just 5 seconds. So what does this all mean? I mean, 5 seconds is barely enough time to take a deep breath. How can you demand a rescuer stop after 5 seconds if they can clearly see fluid still bubbling in an infant's throat?
This raises an important question about the hidden cost of the procedure itself. We have to recognize the physics of the vacuum. The suction machine is incredibly powerful, but it is indiscriminate.
What do you mean by indiscriminate?
It does not know the difference between heavy vomit and invisible oxygen. While the catheter is in the throat pulling out the fluid, it is simultaneously vacuuming out all the residual oxygen from the patient's lungs and airway.
It is actively stealing their air.
It is actively suffocating them. Hemoglobin, the protein in the blood that carries oxygen, desaturates very quickly when a patient is in distress. Every single second that vacuum is running, the patient's blood oxygen levels are plummeting toward brain death. The 15, 10, and 5-second limits are hard physiological red lines.
Wow. So the rescuer hits that 5-second mark on an infant, pulls the catheter out, and then what? Like, what if the airway still isn't clear?
The grading sheet mandates an immediate, non-negotiable recovery phase. The rescuer must immediately begin reoxygenating the patient, usually by actively forcing air into their lungs with a bag valve mask for a minimum of 30 seconds.
30 seconds?
Yes. They have to pay back the oxygen debt they just created. Only after a full 30 seconds of high-flow oxygenation can the rescuer reassess the airway and, if necessary, go back in for another brief sweep.
The level of psychological discipline that requires is staggering. You have to force yourself to stop treating the highly visible, horrifying problem, the blood or vomit, because you logically know you have to treat the invisible problem of oxygen depletion. It is completely counter to basic human instinct.
It absolutely is. It is the defining line between a chaotic reaction and clinical control. It takes profound restraint to watch an airway struggle, pull your tool out, and patiently ventilate for 30 seconds before addressing the fluid again.
To look back at everything we've explored today, the depth of this seemingly simple procedure is astonishing. We examine the deliberate engineering of the rigid Yang-Hauer versus the flexible French catheter. We unpacked the physics of utilizing gravity and the biomechanical awareness required to abandon gravity when the cervical spine is compromised.
Right.
We broke down the facial geometry used to measure insertion depth and the critical physiological boundaries of vacuum pressure required to prevent the vagus nerve from stopping an infant's heart.
Yeah.
And finally, we looked at the uncompromising stopwatch that governs the delicate balance between clearing an airway and stealing a patient's oxygen.
It really is a remarkable sequence of events. And as we conclude, I think there is a broader underlying tension here that makes this procedure truly unique. Consider the evolutionary paradox at the heart of oral suctioning.
The evolutionary paradox.
Yeah. The human airway has evolved over millions of years to fiercely protect itself. Our bodies have deeply ingrained primal reflexes designed to violently reject any foreign object entering the throat. The involuntary gag reflex, the spasmodic coughing, the instinctual clamping of the jaw, these are all evolutionary survival mechanisms honed over millennia to keep us alive.
Right, so our bodies are literally hardwired to fight off exactly what the rescuer is trying to do.
Precisely. In the chaotic moment of a compromised airway, those exact evolutionary defenses are the very things that will kill the patient. The rescuer is not just fighting the physical presence of vomit or blood, they are actively fighting millions of years of human evolution.
That is wild.
The entire grading sheet, the cross-finger leverage to defeat the jaw bite, the precise measurements to bypass the gag reflex, the calculated pressures to avoid vagal shutdown, it's essentially a blueprint for methodically overriding the body's most primal self-defense mechanisms in order to save the body itself.
You are battling the patient's own survival instincts to actually help them survive. That is a brilliant way to frame the sheer complexity of what happens in those critical seconds. It fundamentally changes how you view the raw reality of emergency medicine. Well, thank you for joining us on this deep dive into the meticulously structured world of oral suctioning. We hope this exploration has given you a profound new appreciation for the precision, the physics, and the anatomical awareness required to secure the most basic element of human life. Keep exploring, keep questioning the systems around you, and we will catch you on the next deep dive.